Hello, everyone. Thank you for coming. Welcome to NAHDO's 40th Annual Conference. We will be starting in about 1 minute. Before we begin, we want to cover a few housekeeping items. On your attendee screen, you can enter comments or questions in the chat. We hope you will take advantage of the opportunity to engage with our speakers and other attendees. This session is being recorded. We recognize and thank the California Healthcare Foundation for being our Petabyte sponsors. Information about all conference sponsors is available in the sponsor area of the platform. Please take a few minutes to visit each sponsor's booth where you can find more information about them and find game tokens. Game tokens are keywords or phrases used in the token hunt game for a chance to win prizes in the daily drawings. Now, let me turn the stage over to Norm Thurston, NAHDO's Executive Director. Norm, the stage is yours.
Thank you, Debbie. It's certainly a pleasure to be with you all this morning for our opening session for today. So today I'm going to give you just a few remarks and we're going to get started. First, before we jump into everything, I want to thank again our event sponsors. We can't thank them enough. We want to make sure that they are recognized. We really appreciate their support in making all of this happen. And so hopefully you all can help us. If you know any of these people, thank them for their support. Similarly, we have our NAHDO collaborating and featured partners who work with us throughout the year to provide insights and events and guide our strategic planning for the future. So we're really appreciative of them as well for both their participation and for their financial support. Just a few pro tips for today. We went over this yesterday, but in case you missed that, there is, of course, the conference program and the agenda. The agenda is where, of course, you can find all of the sessions that you need to join. And the token hunt, win prizes. Yesterday, we had a winner of our day one prize. Madison Lopi from Nevada was our winner of the day one prize. So if you haven't been participating, it's not too late. There'll be a day two prize and then a big prize at the end of day three. So every time you find a token entered into the system, that gives you one more entry into the drawing. So it's a fabulous way for you to participate and then win prizes. We also just want to emphasize networking sessions. Yesterday was fantastic. We had 4 networking sessions. They were almost all full all the time. So I hope that wasn't frustrating to too many people that the one that you wanted to get into was full. We apologize for that. They are capacity constrained to make sure that there's a quality experience there. We have added a 5th room for today. It is a open topic, no host. So if you can't get into one of the other 4, just jump into that 5th room and make friends and do that one as well. Also tomorrow morning at 11:30, we will have a virtual coffee shop. And the coffee shop is just less formal. It's a place to come, meet people, talk about what you're doing, what they're doing, and get to know them. Just also keep an eye on the wall. There are a few comments and announcements there. And that is a place for you to express your opinions as well, to talk about what you're doing or ideas that you have throughout the conference. If you haven't already, mark your calendars, May 6th and 7th, 2026. We are looking forward to being in Miami, Florida, and that picture is the hotel that we're going to be at. So that the lower level of that hotel that's on the right, you can see there's a little band around there. We're looking out over that the marina and the bay for our conference. So it's a fantastic location. We also expect fabulous conversations and great content as well. So please mark your calendars for that. Milliman Med Insight will be sponsoring our session today. And so we want to hear just a little bit from Milliman Med Insight. So I'm going to turn the time over to Milliman to say a few remarks. Milliman?
Hey there, I'm Todd Fessler, Chief Revenue Officer at MedInsight. We're part of Milliman, one of the most trusted brands in all of healthcare. MedInsight is a healthcare technology company specializing in data, analytics, and most importantly, insights. After all, insight is in our name. Who uses our products? Hundreds of payers, providers, and purchasers rely on the insights that MedInsight delivers every day. And every day, thousands of users log on to our platforms to get the data and information they need to do their jobs. This could take the form of an analyst looking into an overutilization problem, or a data scientist wanting to leverage AI and ML models to uncover better ways to improve clinical outcomes. It could be an executive preparing for a board meeting and needing key metrics about organizational performance. These are just a few examples of how the market leverages our products. Payers, large and small, have used MedInsight products for more than 25 years. And the number of ACOs now using our VBC platform, well, it's approaching 200. Along the way, we've become highly proficient in managing data. You cannot stick around this industry for 25 years and not be good at handling data. Ingestion, integration, managing. It may not show up in the software as a flashy feature, but data quality is not just a nice to have, it is mandatory. And it's why states like Virginia and New Hampshire have trusted us to manage their APCD initiatives for many years. Our data confidence model helps our customers, it powers our platform, and it has become a real backbone for the MedInsight infrastructure. We've been innovating since our founder, Kent Sasha, started the company in 1998, and we will continue to innovate. Recently, we launched the MedInsight Health Cloud. This was a result of a digital transformation strategy that we embarked on starting in 2020. The MedInsight Health Cloud is already transforming our business. It's absolutely improving the customer experience. That's everything from increased software performance to enabling our AI capabilities. Our Health Cloud offers the market full access to MedInsight's portfolio of analytics, benchmarks, and referential data. We're headquartered in Seattle and have offices across the country. Our employees are committed to our mission of being the healthcare industry's most trusted source of analytics. If you're a customer today, thank you. And if you're not already a customer, give me a call. I'd love to show you around. Thanks for watching.
Thank you, Todd. And again, thank you to Milliman for being our sponsor. We're certainly glad to have you as a longtime partner with NAHDO. So I would like to introduce at this point, this segment. We will be, this part was organized and will be moderated by Chris Krawczyk from California. And this is going to be our annual announcement presentations and I guess general awareness of the NAHDO award recipients. One thing I will note just before we bring Chris on stage is that we've had some requests in the past to tell more about what the award recipients did to earn the reward. And so fortunately, they were all very good natured and have agreed to provide more information about their programs and their experience. So let's go ahead and bring Chris on stage, Charles, if that's okay. All right, Chris, the time is yours. I'm going to turn it over to you and let you take it away.
Great. Thank you, Norm. And good morning to those of you that are in morning still, and good afternoon to those of you that just entered into the afternoon. My name is Chris Krawczyk, and I am the Chief Analytics Officer with the California Department of Healthcare Access and Information. I'm also honored to be a NAHDO board member, and it is my pleasure to moderate this morning's award session and to share with you all the great work of our award recipients. We're going to begin with the Elliot M. Stone Award for Excellence in Health Data Leadership. The Elliot M. Stone Award has been presented since 1990, but first was the NAHDO Award of Excellence in Health Data Leadership, presented to one or more individuals who represent the highest ideals in data collection, analysis, or outcomes measurement, and whose creative efforts have made outstanding contributions to improvements in the collection, application, and/or dissemination of health data. Until his passing in 2005, Elliot Stone helped NAHDO select awardees who made significant contributions to the health information field and who exhibited characteristics of quality, excellence, and passion in their work, characteristics that Elliot himself embodied. In 2005, following Elliot Stone's untimely passing, the NAHDO board renamed its annual award to the Elliot Stone Award of Excellence in Health Data Leadership, in honor of Elliot and in acknowledgement of his generosity, care, and diligence to the field and to his colleagues. Elliot set the highest standards for his own performance and for others to follow. At NAHDO's 20th anniversary meeting in Washington, D.C., the first Elliot Stone Award of Excellence was presented posthumously by NAHDO to Elliot's wife and sons. So with that, it is my honor to announce the 2025 recipient of the Elliot M. Stone Award to Ben Steffen. Now, Ben was not able to join us today, so I'm just going to take a few moments to share a little bit about Ben and his incredible accomplishments. Ben served as the executive director of the Maryland Healthcare Commission for the past 14 years. And during that time, he truly transformed how health data is collected, analyzed, and used to improve healthcare delivery in Maryland. Under his exceptional leadership, the MHCC has developed quality reporting and consumer price transparency programs that stand as models for the nation. Maryland's groundbreaking Where the Cost initiative perfectly exemplifies Ben's commitment to transparency, offering both consumers and policymakers unprecedented insights into the complexities of healthcare costs and quality across providers. This initiative has not only empowered Maryland residents to make more informed choices, but has also fostered greater accountability within the healthcare system. Ben has also been instrumental in systematically expanding the MHCC's data capabilities, overseeing the collection and analysis of a vast array of health data from facilities and insurers statewide. His strategic approach has been pivotal in facilitating informed decision-making for everyone involved in healthcare, from individual patients to those shaping system-wide policy. The robust data infrastructure he has built serves as a vital foundation for evidence-based policy development and crucial healthcare improvement initiatives. What truly sets Ben apart is his remarkable ability to translate intricate data into clear, actionable insights that drive meaningful and lasting change in healthcare delivery. His unwavering dedication to leveraging health data for system-wide improvement, coupled with a deeply collaborative approach to working with diverse stakeholders, makes him an exceptionally deserving recipient of the Elliot Stone Award of Excellence in Health Leadership. So please join me in congratulating Ben and his receipt of the Elliot Stone Award of Excellence in Health Data Leadership. And so next we are going to move to the Data Pioneering Award. Over the years, NAHDO has given awards that recognize an individual's contribution to data use or programming at a NAHDO member health data organization. In 2021, NAHDO established the name Data Pioneer for this award. And it is my honor to announce the 2025 recipient of the Data Pioneer Award to Lorie Geryk, Senior Program Manager of the Washington State All-Payer Healthcare Claims Database. We recognize Lorie's exceptional leadership and unwavering dedication to advancing health data accessibility and transparency in Washington State since the Washington APCD's inception. Under Dr. Geryk's strategic guidance, the Washington APCD has become an indispensable resource for policymakers, researchers, and consumers, fostering greater accountability and driving evidence-based decisions in healthcare. Her oversight has led to the development of innovative tools, including Washington State's award-winning Healthcare Compare website, empowering consumers with price and quality comparisons, and the insightful public use file and air ambulance services dashboards. Dr. Geryk's collaborative spirit extends to state agencies, health plans, and researchers, ensuring the Washington APCD effectively informs policy solutions that improve healthcare affordability and outcomes. A steadfast advocate for health data transparency, Lorie Geryk's commitment has been pivotal in making critical healthcare data more accessible and actionable. And we've invited Lorie to share a few words about her experience in health data.
Good day, everyone. Thanks for joining this NAHDO conference session. I manage the Washington All-Payer Claims Database, and having received the NAHDO Data Pioneer Award earlier this year was a real honor. I'm still over the moon about it to have been chosen, and it was a delight to have Jim Harrison and Norm Thurston present that to me at the NAHDO meeting in Austin. And in my mind, it's really a recognition that after almost a decade of deliberate, incremental work by multiple teams, it's added up to something noteworthy. Today, I'll walk through what that work produced, why it matters, and most importantly, how little of it would exist without our strong partners, stakeholders, and the APCD programs who led the way initially. I'll explain the 1,200-line item Excel spreadsheet in just a minute. We, as APCDs and other data organizations, hold important healthcare data, specifically the kind of data that can influence health outcomes and modify cost. Today, I want to share the story of Washington's All-Payer Claims Database, or WAPCD as we call it, and why none of this happens in a vacuum. So back in 2014, when our state legislature greenlit the WAPCD, we weren't inventing the wheel, we were building a better one, a massive repository of medical and dental claims from multiple payers in the state, private insurers, Medicare, Medicaid, covering over 70% of insured lives here in Washington. It's the most complete snapshot of our healthcare spending and outcomes in Washington state. And that Data Pioneer Award, it's a testament to how we started strong because we could lean on a data vendor who had worked with other states, a web vendor who understood the business of website development. We could talk with those of you who had advice for us and who willingly shared your lessons learned for us to use. We invoked key stakeholders and built strong policy and advisory committees. We had committed and passionate program staff members who strove tirelessly to create and launch this program. Our initial scope of work was a spreadsheet with over 1,200 line items that included specific scope of work, activities, and deadlines. We started taking submissions in 2017 with historical data collected back to 2014. And take our Washington Healthcare Compare website, which launched in 2017. This website was developed in collaboration with our web vendor, Forum One, and our data vendor, Onpoint Health Data. It won NAHDO's Innovation and Data Dissemination Award in 2018, our first big national shout-out. Imagine you're a person in Tacoma, Washington, Googling knee replacement, and you have not just provider names, but prices and quality ratings, all side by side. We've had over 14,000 new visits to the site this year. That's 14,000 moments where someone likely walked away with information and hopefully were better equipped to make a healthcare decision or to request our data. Fast forward to 2019, we had unified our database and had included public employees and school employees' benefits claims as well as workers' compensation claims, boasting coverage by hundreds of thousands of lives. That meant richer data and analytics. More recently, in 2023, we rolled out an interactive healthcare cost and utilization dashboard. These aren't ordinary pie charts. They're dynamic tools letting anyone, policymakers, researchers, patient advocates, curious high schoolers, explore cost and utilization of healthcare services in Washington. We've processed numerous data requests since our launch, so from RAND hospital cost comparison work to the Office of Insurance Commissioner's fertility treatment cost reporting work. One standout, Washington has a cost transparency board, and WAPCD data is used to help them show the legislature how to make good healthcare more affordable. And let me not forget our 2025 website refresh, which will launch at the end of this year, where we'll unveil a whole new way to search for quality and cost for services and procedures and to find a doctor near you. And we will be launching additional data-driven insight pages so you can learn more about how our data is being used here in Washington. But here's the secret sauce. We didn't do this alone. Washington's APCD is a mosaic, pieced together from lessons learned across state lines. This collaborative spirit, it's gold. We're all focused on a similar North Star, affordable, accessible care for everyone, everywhere. Washington's efforts get sharper because other states produce meaningful dashboards, or we get together at an APCD council meeting and talk funding concerns and benchmarking wisdom. So thank you. Let's celebrate this Data Pioneer Award win together. And if Washington's story inspires even one state to reach out for a chat, we've won bigger than any award. Thank you again.
All right. Welcome, Lorie, and congratulations on receiving the 2025 Data Pioneer Award. And thank you also for your presentation and sharing a little bit more about the work in Washington.
Of course. Thank you so much. Glad to be here today.
Yeah, thank you. And we have a little bit of time for some questions, either from the audience. But one thing that I did want to ask and sort of highlight is a goal of NAHDO is to foster collaboration between the states and among the different state health data organizations. And your presentation there at the end, I really liked your line about it's a mosaic that involved collaboration and learning from other states, which is really, I thought, a powerful description. You also mentioned, like, the APCD Council as an example of where you would come together with others. But what are some of the key lessons learned as you've done this decades-long journey from other state organizations, but also what might be some things that were unique in Washington that you can share with our conference attendees?
Sure. So a lot to unpack there. And we initially, as we were getting started, we set up calls with other state programs. We scoured the internet to look at, statutory language and rulemaking details. Other states were always very willing to talk with us and share documentation, for example. So one specific example that comes to mind when we were developing our data release program. So, you're looking to create data products, to price them, to figure out how to disseminate them. And so we, again, learned so much from looking at what others were doing. So reviewing other program data products, their data share agreements. Most folks were willing to kind of even send us templates to help us develop them. So I think we were able to kind of build on that existing knowledge and what was currently out there to improve our documentation and our, all of the steps that we put in place for the data release program was just enhanced by looking to others. I will say too, learnings from, you mentioned Washington State specific. I think it's probably not specific, but initially we learned how important it is to, how important planning work groups are, how important those committees are. We have a data policy committee, a data release committee. We've learned that it's essential to develop closer relationships with, all of our subcontractors, our providers, our submitters. Also, I would say having a 5-year plan and looking at those financial projections, program projections helps you. And even you're revising that as you go along, maybe do a 2 to 3 year plan, but that helps you as we're getting ready to do the statement of work for the following year to make sure we're on track and on target and to revise as needed. I think those things in Washington were really important to get us moving further along each year with the specific goals in mind.
Excellent. Thank you, Lorie. And certainly I think you there just highlighted some really good, specific examples of ways in which there's commonality across the different states. Although we each, have our own uniqueness, just bringing the data release as an example, the data documentation, the pricing policy, the establishment of different committees. These are all things as we've launched, our own data release program that we've had to think through and that we've had to plan through. And so I think some really good examples of, we're not building these alone. We're not maintaining these alone. But again, we can learn and draw from the work of other states throughout the life course of our different programs. So I want to thank you for highlighting those. We are going to move forward with our program, but we're going to welcome Lorie back hopefully at the end with our other award recipients so that we can have additional discussion amongst all of the award winners. Do want to encourage folks in the audience to submit any questions that you might have for Lorie for later on when we bring her back on stage. But next we're going to move to the award for innovation in data dissemination. And we actually have 2 award winners in the innovation in data dissemination category. Each year since 2009, NAHDO has honored an organization with the Distinguished Innovation in Data Dissemination Award. The NAHDO Board of Directors established this award to recognize the importance of effectively communicating health data to the public. While the Elliot M. Stone Award of Excellence in Health Leadership is intended for an individual, the Innovation in Data Dissemination Award is designated to be awarded an organization. The NAHDO Board of Directors established this award to recognize the importance of effectively communicating this data. Eligible organizations may be government agencies, nonprofit organizations, or for-profit companies, and data dissemination efforts might include websites, advertising campaigns, written reports, or a combination of these and other communication initiatives. The 2025 recipients of the Data Innovation Award are California's Healthcare Analytics Branch and the Multistate Behavioral Health Initiative. We're going to first hear from Caily Langston from the Healthcare Analytics Branch, who will describe the work that they've done that forms the basis of their receiving the award.
The Healthcare Analytics Branch, or as we like to say HAB, is a key unit within the Department of Healthcare Access and Information, or HCAI. My name is Caily Langston, and I have the pleasure of both leading this presentation today and acting as HAB's Administrative Assistant Branch Chief. Our vision is a healthier California where we all receive equitable, affordable, and quality healthcare. Next is listed our mission, and last, our values, which we hope you see represented in this presentation. The Healthcare Analytics Branch supports a wide variety of critical data areas, demonstrating the breadth and depth of our team's expertise. From the California's All-Payer Claims Database, or the Healthcare Payments Data Program, to analyzing healthcare affordability, prescription drug cost, and health equity measures, our work informs high-impact policy decisions. We also support data efforts related to distressed hospitals, healthcare workforce trends, and patient-level or hospital data requests. Our team is expanding into new areas, including primary care data and pharmacy benefit manager data, further broadening our capacity to address key challenges in the healthcare landscape. The diverse portfolio reflects our team's strong analytical capabilities and deep understanding of our complex healthcare systems. The Healthcare Analytics Branch supports a variety of patient-level or hospital data requests to ensure that healthcare data is accessible and actionable across a wide range of stakeholders. As you can see on this slide, we have 3 different data request types, which include limited data request, research data request, and custom data request. The Healthcare Payments Data, or HPD, release program is built on strong legal foundation, with regulations officially being approved on November 25th of 2024. The program was publicly launched shortly thereafter on December 17th, 2024. Providing a secure and structured access to one of California's most comprehensive healthcare payments data sets. This initiative is designed to support a wide range of users, including researchers, policymakers, and healthcare stakeholders, by offering valuable data that promotes health system improvements, enhance cost transparency, and enables evidence-based decision-making across our state. The HPD database contains a collection of 4 core file types and collects data from a variety of sources. A unique thing about California's HPD is its size alone. It is quite large. It currently has 7 years of data and 30+ million Californians per year. The Medicaid population alone is over 13 million people. While we do have a lot of capitated encounters, we also have a lot of fee-for-service claims. Here's a look at the snapshot, which is the first HPD product release surrounding the Healthcare Payments Data Program. This visualization gives a view to the user of the data that's available in the HPD. There are 4 tabs at the bottom of the visualization, which include Data Overview, Data Availability, Medical Procedures, and Drug Prescriptions. Each guide creates visualizations and other database products from the information it manages. These products provide context to make data more meaningful and useful. Over the next group of slides, I'll provide a brief overview of some of the selected data products. The Hospital Performance Rating Summary was created to help assess hospital performance and quality of care for multiple outcomes. Ratings for CABG, IMIs, and PCIs are published in this visualization to provide users with a tool to explore and compare state-licensed hospitals from the selected performance measures. The hospital comparison feature allows the user to compare two hospitals side by side. All hospital performance measures are rated better, worse, or as expected by comparing their risk-adjusted outcome with the overall rates for each measure. HCI developed models to measure and predict current and future supply and demand of California's behavioral health workforce. These models utilize licensing data and care delivery trends broken down by role or role group to create supply projections by full-time equivalent or FTE. These FTEs are used in conjunction with actual reported average patient care hours and employment rates from each role or role group to determine supply and demand at the provider level. In addition, these models consider the current and potential future demand for each role or role group based on capacity and utilization rates, as well as provider to population ratios based on setting, and are calculated inpatient met and unmet demand, as well as outpatient met and unmet demand for each role. This is the social drivers of health preventable hospitalization rates visualization. Preventable hospitalizations are used to gauge patients' access to quality primary health care. Preventable hospitalizations provide a method for us to look at the healthcare system in a different way. Groups of patients with more preventable hospitalizations typically have less access to primary care. 6 social drivers of health are examined in this analysis to better understand the relationship between preventable hospitalization rates and the interplay of SDOH and race and ethnicity. This is the emergency department volume and capacity by facility visualization and was created based on stakeholder outreach and their feedback. The ask was to demonstrate how many ED visits a hospital would have to compare that to the numbers of a treatment station that hospital has across the state. The ratio here is measure of burden on the emergency department. So smaller ratios indicate fewer ED visits per available treatment station and a less burden. Larger ratios of ED visits per available treatment station indicate a greater burden. The California Behavioral Health Snapshot highlights reoccurring themes across all of our behavioral health data products, including service, volume, access to care, and health equity. Our behavioral health definition was developed in collaboration with Massachusetts CHIA to ensure accuracy and consistency. These insights are essential for addressing capacity, improving healthcare access, and advancing equity between behavioral health services. Following the previous visualization slides, I wanted to highlight how HAB is actively responding to our stakeholder feedback collected during this year's outreach. We perform our outreach each year to find out what we're doing well and what we can improve upon in the future. In this year's outreach, we heard the themes listed in the dark blue arrows. Anticipating our stakeholder needs, we already had the data products in light blue in the works. We used our stakeholder calls to further gather input to ensure our products meet our stakeholders' needs. Between January 2023 and June 2025, the Healthcare Analytics Branch accomplished a significant body of work that underscores the scope and impact of our efforts. During this period in time, our team released 198 unique public data files to the California Health and Human Services Open Data Portal, or ODP, and published 69 pages to the HCI website, which included 188 data visualizations. Notably, 28 of those web pages featured visualizations or data containing social drivers of health, reflecting our commitment to health equity in the state of California. In addition to this public-facing work, the team also maintained a strong commitment to customer service by responding to over 5,000 inquiries related to our healthcare data. Additionally, our team supporting the confidential patient-level or hospital administrative data requests successfully completed 360 standard requests along with 164 custom requests. After HAB releases a data product, we actively track user engagement across multiple platforms, including social media, HCI listserv software, and the HCI website. This monitoring focuses on the 2-week period following each release, capturing the immediate response and interest in the data. By analyzing these engagement measures, we gain valuable insights into topics that resonate with most users and how our data products are being used. This helps us loop in and look forward to how we are going to adjust and change our data products in the future. Between January 1, 2023 and June 30th, 2025, we delivered over 218,000 emails, with approximately 108,000 of those being open, demonstrating our strong commitment in our listserv. During that same period, our webpage received nearly 20,000 page views. And with our social media, we're seeing LinkedIn as our most interactive platform, showing almost 40,000 impressions. We are so proud of our team here in the Healthcare Analytics branch at the Department of Healthcare Access and Information. Thank you for taking a moment to learn more about our programs, and we hope you have a great rest of your day.
All right, thank you, Caily, and congratulations to the Healthcare Analytics branch from the Department of Healthcare Access and Information. We'll acknowledge that it's also the group that I'm a part of, so just to avoid any awkwardness, but congratulations to you and to the team there. And really, just through the presentation, you can get an idea of just how robust the portfolio of work is that the Healthcare Analytics branch supports. Hospital administrative data, the claims and encounters data, workforce data, cost, social drivers of health equity, data release services, public use files. It's a pretty large, robust portfolio. What are some of the things ahead that the Healthcare Analytics branch is going to be doing that kind of fun and exciting things that we can look forward to in the future?
Great, thanks. But Chris, can I do a quick check? Are you able to hear me? I had some technology issues earlier.
Yes, we can hear you well.
Fabulous.
Thank you.
Great. Well, there's so much to come for us at the Healthcare Analytics branch in HCI. First off, the pharmacy benefit manager data and the dental data for the healthcare payments data program, or the All Payers Claim database here in California. We're excited to receive that and see what our team can do with it. Just this past month, we launched the Data Enclave for the HPD program, with our first projects going out on Halloween. We're expanding our cardiovascular analytics, most likely with a deep dive into TAVR. More information that our team is looking into to kind of figure out where we go next includes looking at more supply and demand modeling, as well as maternity care. Our hospital equity measure program is getting stood up. The first reports were due at the end of September, so really excited to see what that data brings and how our team can analyze it. Just in summary, what our team is really looking to do is to use data to tell the story. We're hoping that with the robust data we receive, we're able to tell a more fuller picture of what is healthcare, what is that story in California.
Great. Thank you, Caily. Again, we are going to be bringing Caily back at the end of the session with the other award recipients for further discussion and to answer questions from the audience. So please, if you have any questions, be sure to submit those so that we can answer those when we bring Caily back. But thank you, Caily, and congratulations to the entire team at the HCI Healthcare Analytics branch. We're now going to recognize the second, I say organization, but really more group of organizations recognized with the Data Innovation Dissemination Award, and that is the Multistate Behavioral Health Initiative. We're going to hear now from Amy Kinner and Pam Mink, two of the participants in this multi-state initiative, and we're going to hear about the initiative and about their project.
Hi, I'm Amy Kinner, Director of Health Analytics at Onpoint, and I'm here with Pam Mink from the Minnesota Department of Health to discuss our multi-state behavioral health initiative dashboards. These dashboards were created as part of our Collective Impact Initiative, which is a pro bono initiative Onpoint created to leverage our nonprofit mission for the greater good, work collectively to have a greater impact, and highlight the critical value of APCDs through new use cases. For this project, we developed dashboards for each participating state. We also created a cross-state key findings presentation and several issue briefs using the cross-state data, with more to come. You can find these on the link below, onpointhealthdata.org Collective Impact. This was the first project of the Collective Impact Initiative, a collaboration between Onpoint and 5 states, Connecticut, Maryland, Minnesota, Vermont, and Washington. And we'd like to thank NAHDO for recognizing this project through the 2025 Innovation and Data Dissemination Award. It was APTD focused, and we used a standard data model and definitions that were standardized to ensure comparability across the states. The dashboards included diagnoses in the population, use of care for patients with behavioral health conditions, cost of care, co-occurring conditions, and social drivers of health. Now I'm going to walk you through some of the methods for this project and show you some examples of these dashboards. First, defining behavioral health. We identified patients using diagnosis codes in the claims to see if they had behavioral health conditions. We also classified those conditions using diagnosis code categories maintained by SAMHSA. In the dashboards, users can drill down on specific categories like anxiety disorder or bipolar or depression to look at rates over time by geography, by age and gender, and so forth. Data are also stratified by major payer type, commercial, Medicaid, and Medicare. For Medicaid, we used managed care and fee-for-service members, and Medicare includes both Medicare Advantage and fee-for-service plans. These stratifications allowed states to participate even if they were missing one of the payer types. An important component of the dashboards was the ability to look at trends over time. We started in 2019 to look before the pandemic, and we went through 2022, which most of the states had Medicare data through 2022. So that's why we used 2022. Users could see trends over time for various metrics, and they can also drill in on data for different years through filtering. Because behavioral health conditions have very different profiles for different age and sex groups, we included the ability to drill in by age and sex. Here's an example of anxiety disorder, which is particularly high in women age 15 to 25. Users can filter by age group and gender to see the top conditions for each group. We also included a full dashboard exploring the use of care among patients with behavioral health conditions. We included a diverse set of utilization measures from ED visits to acute inpatient use, telehealth, psychotherapy, and more. Users could look at the use of care over time by payer, by age and gender, and so forth. Similarly, we included reporting on the cost of care for behavioral health patients. We compared costs for members with no behavioral health condition to those with behavioral health conditions. And we broke out separately the cost for services with a primary diagnosis of behavioral health. As you can see here, members without behavioral health conditions have significantly lower costs, even without accounting for those behavioral health specific services. One really exciting thing about this project is that we were able to create cross-state benchmarking for the prevalence of conditions, use of services, and cost of conditions. Here's an example of that benchmarking showing ED use in Maryland compared to the cross-state average for patients with suicide and self-inflicted injury. Maryland rates, in this case, appear to be slightly higher than what we see in the other cross-state average. We also have drill down by geography, and we allowed users to both view geographic variation within their state and to filter by county and drill in on key measures for each county. A couple more things that I wanted to highlight in these dashboards. The first is looking at co-occurring chronic conditions and behavioral health. For example, here we show ED visits by the statewide average for patients with diabetes but no behavioral health conditions, and patients with diabetes and a behavioral health condition. And you can see the impact of that, a co-occurring condition, and the extenuating health circumstances for people with these co-occurring conditions. We also examined by zip code rural and urban issues, comparing areas that were small town or rural to the urban core areas and looking at utilization measures. And finally, we looked at social vulnerability, looking at areas with high vulnerability compared to areas with low vulnerability within the state. In the upcoming months, we're going to be refreshing these dashboards with a new year of data going up to 2023, providing a new behavioral health workforce dashboard, and then also providing downloadable Excels to accompany each dashboard, which will allow users to do their own research and analysis using the rich data sets that fuel these dashboards. So that's kind of the highlights of the dashboards, and I'm going to turn it over to Pam to talk a little bit more about the participation from Minnesota's perspective.
Great, thank you, Amy. So MDH's participation was motivated by a number of factors and many of the same things that Amy mentioned earlier. So in particular, behavioral health is a really important and timely topic. The work was well aligned with our mission in the health economics program to conduct policy relevant research. And it also aligns well with some of the previous work we've done, including some studies of opioid prescribing patterns and telehealth use for behavioral health care. This was a great opportunity for us to learn from and collaborate across states, and also to make some cross-state comparisons. And finally, my team has limited bandwidth, so it was really great that Onpoint was able to take the lead on this and really do the bulk of the work. And we really appreciated that throughout the project, Onpoint and other states that were able to provide input and suggestions, and that this was welcomed throughout the project. So where are we going from here? What have we been doing with this information so far? We're interested in promoting engagement with the dashboards and raising visibility of the dashboards. We've had 2 presentations led by Onpoint and organized by us at MDH. One was with the executive director of the local chapter of the National Alliance for Mental Illness. And then we also had a presentation with other Minnesota Department of Health staff who are working in the areas or have strong interest in the areas of mental health, substance use disorder, and health equity. So going forward, we're planning to eventually host the dashboards on our Minnesota APCD website as another way that people could reach and use the information, sending out an email to our mailing list that includes an overview of the dashboards and links. And then we're considering the development of an issue brief where we can maybe drill a little bit deeper on some of the topics. And then we'll continue to brief and engage stakeholders as we move into the next version of the dashboards. Thank you. And then we're happy to take any questions.
All right. Thank you, Amy and Pam, and congratulations to you and to all of the members of the coalition on receiving the Data Innovation Dissemination Award. And thank you for sharing also the work and the presentation of the coalition. Question that for me that kind of came to mind, is it's never easy to put together a multi-state collaborative and to bring folks together to do this type of work as a coalition. How did the coalition come together? How did it form? And what were some of the perhaps challenges, but also lessons learned in the early stages of sort of that storming and forming, leading up to the great work in the analytics and the dashboards?
Yeah, sure. I can take this. Can you hear me?
Yes.
Yeah. Okay. So we had decided we were going to do this project and as a multi-state project, and we spoke with different clients and sort of asked if different state clients and asked if they would be interested in participating, and we gauged that there was quite a bit of interest in behavioral health, and we basically offered this up to any of the states that we work with that wanted to participate, and we got quite a few who jumped on board. And then from there, we started a work group and, reviewed, definitions and things like that over the course of, I'd say, 6 months to 9 months, and then went ahead and the team built the dashboards, and then the states reviewed them and had a lot of great feedback. And we iterated from there. So I agree, it's really hard to put together a multi-state project because people are busy. They have different, ideas of where they want to spend their time. We were lucky to be able to get these states together and convene them and get this project done.
Excellent. Thank you, Amy. Pam, anything to add, or should we go to the next question?
No, just to quickly chime in that what I think we really appreciated about the whole process and Onpoint leading it was how collaborative it was from the beginning, through getting the dashboards released. So it was really, a good experience in that way.
Excellent. Thank you, Pam. We do have a question for both of you from one of our audience members and participants, and that's, what topics does the collaborative plan to tackle next?
Yeah, so we, as I mentioned in the presentation, we are currently really hard at work developing a behavioral health provider workforce dashboard that will be part of this suite of dashboards, but then we will also refresh what we've already done. And then from there, we have some ideas, but we haven't landed on anything. We've been talking to different folks like Pam and her team and other states to see what's of interest. What we're trying to do is find something that's can be useful, isn't duplicative of what states are already doing, and can be done in a reasonable time frame.
Excellent. Yeah, the workforce component really caught my attention. Even here at the conference, yesterday in a number of sessions, the impact and the role of workforce, particularly in rural areas, we heard a good bit about it. And, regarding the rural transformation program, is really of interest. Is that work going to be more sort of cross-sectional, looking at the distribution and the availability of different professions? Is it going to be predictive?
Yeah.
Are you going to be looking at like retirements? Just kind of what's the scope of that going to be?
What we're going to do, I believe we're still hammering out the methods a little bit, but is look at this is still going to be within the behavioral health space. So looking at behavioral health provider workforce and looking at where people are rendering services by geography, and then sort of associating that with how people are using care. So are there areas where there are fewer providers, and how does that impact use of care? Are people going to the ED, for example, because they can't actually get in to see a behavioral health professional?
Excellent. Thanks, Amy. And we do have another question from our audience. And so that is looking at different states. Were there areas that couldn't be explored because of differences in data collection and quality?
Yeah, so I think, and perhaps there's another question on this as well. One of the big challenges is that states have very different completeness of substance use disorder data within the APCD. So some states have, we believe, we've done some evaluations of this. We believe some states have very complete substance use disorder data. The payers that are submitting to the APCD in certain states are sending that data. And then in other states, it's lagging, and we don't believe that substance use disorder data is very complete. So that was probably the biggest challenge that we had, is kind of dealing with that. I think other challenges, just like some states had more recent data and other states are lagging a little bit in certain payers, particularly Medicare. So having to figure out how to address that and work around that.
Excellent, thank you. Yeah, I actually was going to ask about the SUD data in 42 CFR and Part 2 and the impact on using the data, but also just on the availability and on the actual outcomes. I did notice like there were lower percentages across the different dashboards in terms of where SUD appeared. Okay, so let's go ahead, and we are going to bring all of our award recipients back up on stage. And again, if anyone in the audience has questions for all of our award recipients, please feel free to enter them into chat. And I'll go ahead and I'll just sort of start it off with, I asked the lessons learned question of Lorie, and then others, and I myself asked of Amy and Pam. Let's go to Caily. Caily, what have been some of the key lessons learned as the healthcare analytics branch has expanded out its portfolio?
So many lessons have been learned, Chris, as you know. With our group, we really want to make data products that our stakeholders want and need. And so to do that, it starts really with the human-centered design. We do that with our stakeholder engagement, hearing what we do well, what we want in the future, And then after we publish these visualizations using business intelligence like Hotjar, Google Analytics, other things to see how our products did and what we can do to improve. Each product is a generation. So as we go through each generation of that project, we are hoping to improve upon it, really taking an iterative approach. We really have that growth mindset, looking at challenges as opportunities, even on the hard days. And then it really comes down to our people. We have such a great staff that has a breadth of knowledge and kindness that is hard to beat. And so working with those individuals have really demonstrated what we can do when we work together. And I'm so thankful for our team to have put together so much over the past several years.
Great. Thank you, Caily. You know, a big part of, again, the conference and NAHDO goal is bringing people together, forming coalitions, forming collaborations, partnerships. It really does come down to, like, the connectivity. And again, in some other sessions that I've been a part of, folks have talked about engaging stakeholders, engaging with their partners. Pam, in the presentation, you mentioned work and in terms of engaging, folks in Minnesota. When you think about, like, again, that stakeholder partner engagement component of this, what are the most effective ways for engaging with your stakeholders, engaging with partners? Is it, different committees? Is it task forces? Is it work groups? Is it surveys? Just what has been most effective in terms of getting input and feedback from those that you're trying to put data into the hands of? And open that up to all the participants, whoever wants to jump in first. Otherwise, I'll call on folks.
Well, I can say a little bit more about what we did, at least for the behavioral health dashboards, is still kind of a work in progress. But since kind of the first wave of engagement for us was we wanted to bring awareness to these dashboards, and especially to the Minnesota specific dashboard. And we did it by kind of presentation and conversation. And then, we'll have, I think, another round when we're able to host them on our own site to revisit, because a lot of what we heard from people is like, this is really, the dashboards are really interesting. I'd like to spend more time with them. And so, the first for us is sort of an introduction, and then, coming back around to find out more, because I think it's there's a lot for us to learn from this process, as well as getting awareness of the dashboards out there. So I think what someone said earlier about, trying to be human-centered and understand what people's kind of wants and needs are, and then try to meet them as best we can, but always kind of learning along the way of, like, what works and what doesn't, and continuing to try to adapt.
I'll add a little bit from Washington. So, how to get the data products in the hands for those who can really make good use of it. And in retrospect, I would say from a communications and marketing standpoint, having, allocated larger budget to getting the word out, about our website launch, where you can find out about, what data products we have, how much they cost, promoting that data release program. And I will say on the flip side of that, despite not having a large budget to work with initially, we've really seen an increase in awareness, from researchers and from policymakers over time. And that's really been evidenced in the fact that each year we're seeing an increased number, like during legislative session, of, new language saying, this agency should use APCD data for these reporting purposes. So it's really been a pleasure to kind of see that growth and interest over time.
And Caily, did you want to jump in at anything?
Yeah, I think, what's been said here a few times is really being responsive to our stakeholders, and in what ways can we connect with them? Is it through these conferences? Is it through stakeholder specific outreach? Is it through Google Analytics? Really making sure that what we are producing is meeting the needs and wants of our stakeholders, I think really drives value to our products, and then we see them getting utilized in more ways across the board.
Great. Thank you, Caily. And we do have another question from our audience participants. And again, open this up for all of the award recipients. But from Heather, has there been public appetite for having such dashboards in different languages? And maybe go to, let's go to Amy and to Pam first. Any insight on appetite for having these dashboards in different languages?
For these dashboards, we haven't had that request. I know for some of the work our team has done, there's requests to translate websites and things like that as part of the scope into, Spanish or other languages. So having that as a capability of the website.
Yeah, I haven't heard anything directly from the Minnesota groups we've shared this with, but we'll certainly keep an ear out for that as we continue to spread the word.
And for our dashboards, I haven't heard that as well. But an interesting part where we have heard feedback around languages is how do we break down languages? If we break down languages to a smaller point, we run the risk of de-identification, or identification, I should say. And so it's really important that we put out actionable data that is also keeping the patient safe. So one thing our team really works on is what are the language categories and how can we break those down at the most actionable level?
And Lorie, I think you were going to possibly jump in also, or?
Yeah, just simply, we tackled a website enhancement project a couple of years ago in Washington where we added a language translator feature, but we have not yet to date received a specific request from an end user of a dashboard, for example, asking if that could be produced in a different language. But it's it's an interesting question and something we will take back.
Yeah, I definitely agree on Heather. Very interesting question. And thank our award recipients and panelists for answering the question, and then also again for your presentations today and sharing with our audience the work that you all have been doing. I do want to just again acknowledge the award recipients and say congratulations to Ben Steffen, our Elliot M. Stone Award winner, to Lorie Geryk, our Data Pioneer Award winner, to the California Department of Healthcare Access and Information, Healthcare Analytics Branch, and then also to the coalition and all of, the coalition member states for the great work that they've done, but to Amy and to Pam for your work and for your being here today to present. I'm going to hand it back to Norm now, who's going to go ahead and is going to do some additional, I think, house cleaning and some announcements.
Thank you, Chris. Certainly, it was exciting to hear all of your comments and your experiences with your various projects. Coming up next, we have 2 breakout sessions at 1:20 p.m. Eastern Time. These 2 sessions, one of them will be one of our advanced analytics section, and that session will be focused on applications for uncovering spending variation, climate impacts, and health disparities. So if you're an analyst and you're interested in those topics, there's something there for you. The other one is going to be another one in our how-to series, and this is going to we'll have 3 presentations on how to improve the quality of your data. So again, a common problem that people are asking us all the time. So we've asked 3 panels to come and share with you their ideas about how to improve the quality of your data. And both of those will be starting at 1:20 p.m. Eastern, so in a roughly 15 minutes. So see you all over there. And thanks, Chris. Thanks, everybody. And congratulations to you all. And we'll see you again soon.